It is such a great honor for me to be able to give this Claude Organ Jr. Memorial Lectureship toward the Southwest Surgical. This has been a dream of mine to be able to be an invited lecturer at this society. I first attended my first meeting in the late 1990s, and I think I just looked it up. It was probably 1999 down in Coronado. And upon going to that meeting, I knew that this was a society that I would be a long-term member of. This organization offers what I really value most in a surgical society. It's got great science, diverse topics, collegiality, and even though I state on this slide that I don't have disclosures, I do love golf, and this meeting has golf. I've met, when I first came, I kind of came alone, and I didn't have any teams. That Dr. Postier wouldn't let me on his team because he didn't think I was good enough, and so I just kind of joined some teams and met some great people that have been friends of mine now since I started with the society. They don't let me on their teams anymore either, so that might say something about my golf, but I can hit pretty far. But Tabitha outdrove me quite a bit yesterday. You can't give this talk without saying a little bit about Claude Organ, and I read his speech from his presidency of the American College of Surgeons in 2003, "You Can Make a Difference," and this really resonated with me. Education, research, and improved patient care are common bonds that unite us. Surgery is not a spectator sport. As you know, I do love sports. And you can make a difference in everything you do, and especially in surgery and the care of your patients. So I try to follow this advice in my academic career. Additionally, I want to publicly thank Ronnie Stewart for his support in my career, the opportunities he's given me in this society, as well as in other surgical societies and organizations. I want to thank you again, Ronnie.
Thank you, Raj.
I first hesitated when offered the most recent opportunity giving this lecture. However, when he stated I could talk about what I was passionate about, my anxiety kind of went down. I am a very anxious person. I really don't like being up here, but given this opportunity to talk about passions, I couldn't pass it up. But then I went, wow, what is my passion? Well, I read Dr. Kathori's Lessons from the Lake and said, oh, wow, there is something, maybe I can correlate my role as a captain on a boat, and this is me as a young child on the Mississippi River on a houseboat, and yeah, I maybe looked at trying to be a captain of a larger yacht. I actually had a boat that had my last name or my name on it, Roxy May, as most of you may know that's my middle name, but it wasn't this big boat. It was a little fishing boat that's what we used in the Canada lakes to go northern and walleye fishing. And then I thought, well, I gave that up. I couldn't be a captain, so I always went out on boats that had captains on them, and it's kind of a family thing for us to go fishing. And I thought, well, maybe I could lay on the dock and take some pictures of fish in different lights, like Ronnie did to Blue Bonnets. But, I thought, geez, I'll probably get arrested for that. They wouldn't be as nice to me as they were to Ronnie and let him lay there taking pictures of fish. But and then there is family that I haven't spent enough time with through my career as a surgeon, and now in my later years I've been able to do that. Well, then there's teams. As Ronnie said, I was captain of a softball team. I won a gold medal rowing in the past couple years. And then the team that I'm most proud of is the team that we have at OU Medical Center, the trauma team that I work with on a daily basis and that supports me and lets me do what I do, and they take such great care of patients. But been there, done that, got the paper, got the t-shirt. What am I passionate about? Well, for the past 25, 30 years, it's been patients. And it's so incredible to be able to take care of people that, give back to you, as I've said. Aaron here was injured in an ATV crash, and he's given back. He does safety now for ATVs and gets out there and teaches kids to wear helmets and protective gear. We've had freshmen in college who had a liver laceration and went through somewhere around 50, 60 units of blood, and he and his family saved the trauma center. When we were going to close, they went down to the legislature and told their stories, and we got funding to save the trauma center. And I'm going to have to digress a little bit about this guy here. Caring for him and his mother, his mother had lost her husband a couple months before. This guy was shot in an accidental hunting accident and had a pneumonectomy. We spent the whole summer, Pam Roberts and I, trying to keep this kid alive and not have her lose two of her family members. And it was we went through several communication issues, errors that occurred, things that we had to correct. And through that summer, I got as close as I could to compassion fatigue that I'd ever been in my lifetime, and actually did take a month off to recover and reflect on what I was doing and the care of the patients. But during that reflection on that experience, I saw the good that came of providing for a safe environment for patients and their families, and I clarified what I was going to talk about on this talk. So some more disclosures. I'm not Lucian Leap. I'm not an expert in patient safety. I'm not Peter Provenost. But I do, Josie's story is about a child who had many communication errors and coordination of care errors that occurred during her stay in a hospital and died. And I've reviewed several of those cases in my career. I'm not Atul Gawande, but I do have a scowl kind of like Atul Gawande. You don't want to see that if you're the residents. But I do believe in checklists, and long before his checklist manifesto, I was using checklists to go through things with fellow residents or interns that I work with or residents that I worked with, and this is what you need to do and what you need to go through each day that you come into work and how you write orders and how you do op notes and all those things. So. I've been long-standing in in performance improvement and patient safety. I've been on a professional standard committee. As trauma medical director, I chair the Trauma Performance Improvement and Patient Safety Committee, and been an ACS COT verification review site visitor. And I've learned a lot about how to do performance improvement, how to improve systems. I try to teach it when I do these site visits, and I learn a lot from the people who do patient safety and performance improvement at the various trauma centers. And as Ronnie said, I'm now patient safety medical director for the OU physicians. So a little bit about the boring part of the talk, which is what is patient safety? It's a construct that implies behavior intended to minimize the harm to patients through both system effectiveness and individual performance, designed to avoid injuries to patients from the care that is intended to them. Well, something simpler, the WHO is freedom from unnecessary harm or potential harm associated with health care. The ACGME has also now changed the way it reviews training programs. As you all know, may know or have experienced, that it's developed a new review process for training programs. In the clinical learning environment review, it looks at the program and institution attributes that have a salutary effect on the quality and safety in settings where residents learn and on the quality of care rendered after graduation. It has 6 focused areas: supervision, transition of care, professionalism, healthcare quality and healthcare discrepancies, duty hours and fatigue management, as well as patient safety, which I want to talk about today. There's core recommendations for faculty development that is a shared common academic and clinical vision for patient safety, integration of quality and patient safety concepts into meaningful learning experience for residents and fellows. And finally, that this is supported by the college with identification and development and support of a critical mass of faculty who are expert in quality and safety. There's pathways in the safety focused area, and the three that I want to talk about today is reporting adverse events, close calls, culture of safety, and then resident, faculty, and fellow experience in patient safety investigations and follow-up. So the first pathway talks about the roles and responsibilities of reporting, how to report, and does your facility have a central depository for that or repository for that. First, some definitions. What's harm? Harm is an unintended physical injury resulting or contributed to by medical care that requires additional monitoring, treatment, or hospitalizations, or results in death. Sentinel Event, I'm sure you all know about this, is an unexpected occurrence that results in death or psychological injury to a patient. A transfusion reaction that causes death, a medical error that causes death, or abductions from the facility that cause psychological injuries. They're called Sentinel because they are immediate, and immediate investigation and response needs to occur. And most hospitals have policies in regards to the reporting of Sentinel events. The serious reportable events, or the never events that you know about, are preventable, serious, and ambiguous adverse events that should never occur. Death or serious harm to a patient that results in an error or a lapse in healthcare facility. And again, this list of reportable, serious reportable events just keeps on growing in hospitals, and we are required to report those to healthcare forums. In the hospital and in the areas of surgery, it's wrong site surgery, wrong patient surgery, wrong procedure on the patient, foreign body retentions, and death within the 24 hours of an ASA Class 1 patient. So errors, what are they? It's a failure of a planned action to be completed as intended. There's slips, which is an observable thing. You push the wrong button, you hit the gas instead of the brake. Some examples I thought of is there's been reports of patients being transported to the PACU from the operating room with CO2 instead of oxygen and suffering hypoxic brain injury. My own experience, I reviewed a case where somebody ingeniously attached a oxygen tank to where the CO2 tank should have been for a laparoscopic procedure. And they touched the cautery and there was a spark. And they were like, well, that's really weird. Why was there a spark? And the anesthesiologist actually saved the day. Can you believe that? And said, I wonder if there's oxygen hooked up to that. They opened up the back of the laparoscopic tower and there was a green tank instead of a black tank. So those are slips. And lawyers just love to watch us fall and have those slips. What is a lapse? Well, lapse is non-observable. I forgot. Well, I put a central line in, forgot to get an x-ray, the anesthesiologist calls you in a little while, says, hey, your patient's hypoxic. I got a chest x-ray, they have a tension pneumothorax. Well, that was a slip. Maybe your judgment was clouded because you were psychologically or physically impaired. Psychologically, in that you were angry that the case went late and this should have been done several hours ago, so you made that lapse. You were anxious because it was an attending who you couldn't let down, and that you forgot because you were anxious. Psychologically or physiologically, you were tired. You'd been up all night and this was the last case that you did that day before going home. So things happen. Mistakes happen. What's a mistake? It's the wrong plan to achieve an aim. It's knowledge base. Case where you admit a patient gets admitted to the medical service, septic. They look at the chest x-ray, they see that the patient has a left lower lobe pneumonia. Aha, that's the source of the sepsis. Well, they failed to see the free air under the right hemidiaphragm, and they went on to treat the patients for sepsis, and 4 hours later they finally get a phone call from the radiologist who says, hey, do you know that patient has free air? And then they call the surgeons, and the patient has a delayed diagnosis, and it impacts his care. So that's a mistake. And then there's violations. These are deliberate deviations from an operating procedure or a standard of rule. You cross the line. We have a specific policy in how you should put in central lines to decrease infection rates, and you don't want to do that, or you don't want to do the timeout. These are opportunities for somebody to stop the line, to cuss, okay? I am concerned, I'm uncomfortable, and this is a safety issue, and we need to stop the procedure now. A nicer way to say it, and not like I do sometimes, is just stop. Okay, let's start over, is I need some clarity. So you're in the holding area and residents over talking to a patient, and the holding room nurse comes up to him and says, hey, I need some clarity. Can you come over here? That's an orthopedic patient. That's not your patient you're talking to, okay? I need some clarity about this. Physicians and nurses need to accept the notion that an error is inevitable, accompaniment of a human condition. It's even among the conscientious professionals with high standards that we do have errors. Errors must be accepted as evidence of system flaws and not character flaws. We're always going to have, sometimes we try to do our best, but sometimes we do have slips and lapses. Types of errors, there's diagnostic errors as I talked about, there's preventative errors, we forgot to give the antibiotics as we are supposed to before the surgery begins, there's errors in treatment, wrong medications, wrong drugs, not responding correctly to abnormal tests, but the majority of errors are failure to communication, as was talked about in previous talks. We as medical professionals don't like to talk about errors, so we name them something different. We say, oh, it's an unanticipated outcome, iatrogenic injury, a therapeutic misadventure, or glitches. But these are all medical errors. What we want to do is keep them down in the blunt part of this triangle. We want to keep them down in the hazards, near miss, and minor injury, and not have serious injury or fatality. So what is a no-harm event or a near miss? They classify them in different categories. One is an event that didn't reach an individual because of a chance alone. Nurse walks into the room, is going to hang a medication, family members there, says, hey, what is that? Well, it's penicillin. Oh, well, she's got a penicillin allergy. Why are you giving her penicillin? Oh, this is not her, okay? I need to do my scanning and not give the wrong patient the wrong medication. So the family catches that. The event that did not reach the individual because of an active recovery efforts by caregivers. I was in the ICU one day, and a nurse, one of our good ICU nurses, came up and said, hey, when did you guys start giving IV heparin post-operatively for VTE prophylaxis? I went, IV heparin? Well, yeah, the resident wrote for IV heparin. I go, I don't think so. And if you look at the way we have that listed in our EMR, IV pops up first. So we changed some processes in that sub-Q heparin shows up first in your pick list instead of the IV heparin. And we were able to catch that near miss. Next is an event that reached the individual but did not cause harm. So a patient gets my example of this one was two patients are down in the cath lab. One that's getting a IVC filter because they can't be anticoagulated. The other one's getting a cardiac procedure. Medicine resident picks up a sticker and puts in orders for post-procedure care. Grabbed the wrong sticker. The next day, an astute resident on the trauma team goes, why is this patient on aspirin? And goes through, finds out who wrote for the aspirin and said, this guy is not part of our team, calls him up and clarifies the error. So the patient didn't have any harm, but got a medication that could have eventually caused harm had we not caught this. An event reached the individual and required additional monitoring or treatment. Those are the slips and falls that occur in the hospital. People on anticoagulation hit their head. They get a CT scan that's negative, but they require them to stay in the hospital a little bit longer for routine physical examinations and neurological examinations. So why do we report no harm events? Well, it enables us to be proactive, to resolve those hazards. It engages our workforce to make them feel good that they caught something that might harm somebody before it does. It increases safety ownership and reinforces workers' self-esteem. It exposes valuable information that otherwise might not be discussed among team workers. And it develops a positive attitude surrounding safety. What additional things should we report? Well, we should report any investigations that we hear of, any peer review notices that we receive, any subpoenas. And I'm unfortunately get all these subpoenas from workman's comp and criminal cases, but I need to report those to the appropriate risk managers to ensure that I don't inappropriately give information about healthcare information. And then claims and lawsuits need to be reported. Well, how to report? Every place has their own little mechanism on how to do it. Ours is a phone number that you call that tells you who to report it to, and that's our OU physicians, risk management, and then they send it on to the hospital. But there's hotlines, there's websites, there's QM modules that are most of the time so difficult and so arduous that people don't use them. And then there's patient and family complaint lines or employee complaint lines. Most of these are anonymous lines that you can use, and some, if you want to be identified, you can also be identified. So why don't people report? We found this out in our Claire visit, is they don't want to take the time or effort to support. It's not worth it because doesn't change anything is what they feel. They don't get any feedback. It's somebody else's role. They always think, well, I'm an intern, it's the chief resident's role. The chief resident thinks it's the faculty thinks it's the nurse's role, or the pharmacist, or whoever. Somebody doesn't take the initiative. And then what surprised me is some of the residents felt like there would be punishment or backlash if they reported. So we need to develop a safety culture. And it's where we have shared perceptions and attitudes about the policies and procedures related to safety by group members. And it's a deep, not visible, it's history, it's artifacts, it's symbols, it's an infrastructure that is not easily measured, but it's a culture that wants to do the right thing for patients. Most of the errors that we experience are the perfect storm. It's not the individual. It's just a multitude of errors that follow each other over and over. It's faulty systems and processes and what conditions we're put into. It's that line that lines up with the Swiss cheese. You get communication problems, you get lack of supervision, inadequate training, poor technique or inadequate technique, and you get an adverse event. So there's 5 attributes for a safety culture. One is all workers accept responsibility for the safety of themselves, their co-workers, their patients, and the visitors. They prioritize safety above financial and operational goals. They encourage and reward the identification of safety issues. It provides an organizational learning from accidents and provides appropriate resources, structure, and accountability to maintain effective safety systems. It's a generative culture. It's not bureaucratic. It's not pathologic. It seeks to actively find issues, finds failure. Failures lead to formal reforms. There's new ideas that are welcome. And above all, the messengers are trained and rewarded. There's one system that I looked at that they did chart reviews and they found if errors occurred, whether medication or care issues, and they actually penalized the departments if they did not report them. So they really wanted to come up with this safety culture and have people participate. So what are the deterrents? Well, we have a very hierarchical healthcare system. We have a bunch of individual experts that are only in their small little area of expertise. We lack interpersonal teams at times, and there's lower levels. The lower levels aren't confident that there is a problem. They may not understand that what's happening is actually an error in technique, and they aren't confident enough that they know that there's a problem there and that they should stop the line. So what is a strong safety culture? It's group values. It's teamwork, participation, and cohesiveness. It's got characteristics that are psychological safety, that you're not going to be harmed if you report something. It's got active leadership. You're out there. You're walking around. You're talking to people. You're trying to find if there's issues. You're kind of nosy about things. There's transparency. When something occurs, you talk about it. If there's a potential preventable death, you talk about the issues that were around that event and you try to prevent it from happening again. And then there's fairness. There is not any penalty to the lowest person to stopping something. A clerk can hold up a surgical case because the appropriate consents aren't there. The blood consent's not there. That's fair for them to do that, and they shouldn't. They should be rewarded for stopping something that could lead to an error and not be penalized for that. And the reward of being in a strong safety culture is that there is better outcomes. It's been proven in the past. So Provenos again talks about this team approach in his comprehensive unit-based safety program, or the CUS program in his book, Safe Patients, Smart Hospitals. The goal was in his system was to improve outcome, and they did it by increasing teamwork. They made multidisciplinary teams, multi-professional teams, including doctors, nurses, techs, anybody who was involved in the care of the patients in the units that he was working. And they increased communication. And the thing they asked was, how do you think the next patient might be harmed? And what are we going to do to prevent that? And came up with a excellent program that improved outcomes and cares. Well, there's been a little bit of a shifting culture that, not everything is the system. It can also be that there is some individual responsibility, that there's certain areas that actually demand individual accountability. There are people out there that are reckless, and potentially there's intentional acts that could lead to harm. And then there's people who just don't want to be part of the team, and they don't promote team behaviors, and this shouldn't be tolerated. This has fashioned the new or another type of culture, which is called the fair or the just culture. You can still create safe systems, cultivate a learning environment, and have an open culture, but you need to manage behavioral choices. Some of them are errors and slips. Those are easy to take care of. But when people have shortcuts and at-risk behavior or reckless behavior that blatantly ignores policies and procedures, they need to be managed. So this is the accountability triangle that Hickson talks about in a lecture that I heard. And there are certain egregious acts that are actually mandatory, and they mandate reviews and potential letting people go. And these are single acts that potential sexual misconduct, coming to work impaired, situations of abuse or discrimination. Those are egregious, and those need to be acted right away, and they need to be taken care of immediately. But in the other areas, there's several questions you should ask about their accountability. Did the team member intend to cause the harm? Did they knowingly and unreasonably increase the risk? Would another team member in the same situation act in a similar manner? And do these individuals have a history of similar events? So if it was a single unprofessional event that caused the incident, maybe just sit them down. And he talks about having an informal cup of coffee with them to talk about the event and see what was going on around the time of that, and to see if there was some home problem or emotional problem or physiologic or psychological problem. And most of them, about 70% of the time, you can nip it in the bud and say, okay, this isn't going to happen again. And then there's maybe an apparent pattern that they need to be a little more aware. So you sit down and have a more in-depth conversation about behaviors and maybe consequences if they don't change those behaviors. And then if the pattern persists, then they probably need a guided intervention, which means a co-developed plan by somebody of authority who they actually will trust, and they and that authority figure come up with a developed plan. It means there's a defined time frame and there's defined consequences if they don't follow that command or that plan. It's similar to, there are certain people out there still that don't want to do the safety checklist. Well, that's not tolerated. We need to follow the safety checklist in the operating room. Another thing, kind of a controversial paper that Provost published in 2009 in the New England Journal of Medicine was balancing no blame with accountability and patient safety. And what he suggested was penalties for failure to adhere to practices. In the area of surgery, if you didn't perform the timeout before surgery, well, you lost your operating room privileges for 2 weeks. If you didn't mark the surgical site before surgery, you lost your privileges for 2 weeks. These penalties would be applied only in cases in which the clinician did not respond to initial warnings or counseling. So it wasn't the first-timers, but it was those people who egregiously continued to not follow procedures and policies. Well, I want to finish up here with talking about experience and engagement in patient safety investigations. We have root cause analyses. We invite the residents. Some of the residents don't think it's as important to go to those, but we've actually developed a way that the program directors now know when there's a root cause analysis that's going on, what residents were involved with the case, which ones were invited, and we make that an opportunity for them to attend. That's a very high priority that they attend these analysis events. The most common ones that is talked about in the literature in the area of surgery is the fishbone type analysis or the root cause analysis. Most of these are based on something that occurred in the 50s with Toyota, asking why in every time that there was a potential error, why did it happen? Ask it 5 times until you get down to the root cause of it. What is root cause analysis? It's a systematic search for contributing factors and causes of errors or adverse events that can be improved or prevented. What is the root cause? Well, it's a weed. It's not a bluebonnet. It's a weed. It's not a pretty weed. And the root is what's below the surface, what caused the problem. So underlying causes that allow the error to occur, things that can be reasonably identified, things that can be fixed, and things that for which effective recommendation for preventing recurrences can be generated. The purpose of the RCA is to not look at individuals, as I just talked about, but to understand the system and the factors that were present that increase the likelihood of the event. The process involves, I think it's best to meet as soon as you can after the event, but you've got to give a little bit of time to gather the information, a description of the event, the timeline, and the services involved. So we usually try to do these within the week of the event. It's review the literature, so you have that available, gather up your team, find the contributing factors, the root causes, and then do an action plan. And JACO, or Joint Commission, requires that this action plan be completed within 45 days. So what about the team? You need a leader, an advisor, and a recorder, and then your team members. Your team members don't always have to be the people that are involved in the event. They may be too close to the event to be objective about what caused the events, and there may be some personality conflict in that. So sometimes you'll have to choose individuals who are close to or have a fundamental knowledge of the issues and the processes that are involved, and then later bring the people who are involved in the event in. Risk managers are there, patient safety officers, quality officers, and then occasionally family and friends. Patients themselves are involved in these root cause analysis. So what do? You go through, okay, what happened? Why did it happen? You review what could have happened, what should have happened, and determine the cause of why it didn't happen. What are we going to do to prevent it from happening again? You want to develop some causal statements, generate a list of recommendations to prevent the recurrence of the event, and then to write a summary. And the key is to share it with leadership, share it with the staff, and share it with those involved so that they learn from it and that the same mistake doesn't happen again. The Joint Commission has a 24-question type of guideline to fill in. You don't always go through all the questions, but it gives you a guideline of how to conduct the root cause analysis. The American College of Surgeons, through the NISQIP program, has developed a training initiative and there's a chapter on root cause analysis. I think the best place that I've found information is at the Veterans Affairs website under patient safety, and they go through root cause analysis, give you several examples, and formulate plans from there. Most of it involves this diagram, which I got from the ACS pamphlet. You want to look for the root causes, whether it's pre-op, intra-op, or post-op causes of your wound infection, and then say, well, we're not using chlorhexidine baths, we don't do appropriate hair trimming, the patient did it on their own. What about intra-op? Well, we're not so good at giving that second dose of antibiotics that we need to give in the middle of the case. That could contribute to that, and what are we going to do to improve collegiality between the anesthesiologists and the surgeons to make sure that occurs. And then post-op, what we can do. You can make the fishbone as big as you want and include as many people as you want in the blame game, but again, it's not a blame game. So you could look at environmental, equipment, leadership, communications, the people involved, and the procedures involved. So you draw up one of these, find the root causes, and then what contributes to each of those. The actions that you need to do are linked to the identified causes. They address all the root causes. They're designed to reduce the likelihood of recurrence or severity of the outcome. They're clear and concise. They get kept to a minimum. They're doable. They're prioritized. They're measurable. They're achievable, realistic, and timed. And you can set up a diagram. And the ones you really need to do are the ones that have high impact and low resource. And this again comes from the ACS NISQIP pamphlet. I don't agree with this. You know, if you define that there's something that you need to fix, even though it's low impact and it may have high resources, you need to try to improve the outcomes. So the limits of these RCAs are they're uncontrolled case studies. They're not all good RCAs. You really need an experienced, trained leader to conduct the RCAs. Experience and willingness of the participants. Some come and just sit there with their arms crossed and don't want to participate in it, think that it's not going to be useful. And then sometimes I've been in some that are very contentious and there's interpersonal differences and it turns into a fight and your leader really needs to control the situations. The biggest impediment is the time that it takes. These can take many, many man hours or physician hours or personnel hours to conduct them. You need to, formulating corrective actions sometimes is difficult. There's lack of feedback to all the providers involved in them. And then it's just a single event. There's not a lot of interaction within the systems to say, okay, we did this event, you did that event. Let's look at things that will be commonality between them. You can do these root cause analysis within your M&M conference. You can use the SBAR, and I lined this up, what happened, why did it happen, what's going to prevent it, and what changes are we going to make. This again is from the ACS pamphlet on how to conduct an appropriate SBAR M&M conference and line that up with a potential root cause analysis. So in summary, medical errors exist. Their harm is usually bad systems, not bad people. Individuals cannot improve safety by themselves. Safe care means shared responsibility, reporting, teamwork, analyze and interpret the data, have measurable goals and objectives. What can we do to support patient safety? Be a leader, devote time, attention, and passion to the safety of your patients. Create an environment that welcomes suggestions, facilitate communication and teamwork, take action when concerns are identified, seek stakeholders and input from key stakeholders, and share the results. I want to leave with one thing that's kind of teed into what Ronnie talked about in professionalism. Profession status is not an inherent right, but one generated or granted by society. This obligates surgeons to put their patients' interests, and I put in their safety, above their own. I want to thank you again for the honor of being given the privilege to give this esteemed lecture. Thank you.